Our core, thanks, Adam. The core of our program and the heart of the program is our Wall Family Speaker Series on Health, Spirituality, and Religion that happens every month during the academic year. But occasionally we will have smaller, more intimate conversations in the evening around topics that are a little bit more heavy, and that's what we have come around together tonight to do. We are thrilled to be moderated tonight by Dr. Rebecca Rao, who is one of our former medical students, who has since graduated and now is an intern. And she is really a brave soul, because when she was a medical student, I'll have her talk more about this, she decided to delve a little more deeply, I think, than most into what does it mean to have proximity to suffering. And she interviewed physicians in a capstone project, and we're going to be talking about the fruits of that project tonight. Before I introduce our panelists and Dr. Rao, I just want to have a few announcements this evening. So the first announcement that we have is we're really excited for our Wall Family Speaker Series in March later this month, on the 22nd. We are thrilled, as we do every year, to showcase projects that are done by our own internal folks here on the domain of health, spirituality, and religion. So we will have trainees and medical students present their projects. That will be March 22nd, which is a Friday, by Zoom at noon. And we're really also excited in April to have secured Dr. Laura Botter. She is a physician who will be speaking on finding joy and meaning in clinical medicine. She'll be speaking on April the 30th, and information about her and her work will be found in our HSR email. We are also open for applications for next academic year student fellows. So as many of you know, we have student fellows for senior medical students who are really a core part of the program, who help us with all aspects of the program and are supported and mentored in ways that sort of speak to the intersection of people's interests in health, spirituality, and religion. So if you are interested in becoming a student fellow for next year and you're a medical student here, please talk to myself or Adam or one of the current fellows. A couple other events on campus. I will be on a panel with American historian of religion, George Marsden, at the Michigan Christian Study Center on April the 18th. And the Conference on Medicine and Religion is coming up also in April in Indianapolis. Happy to speak to anybody who wants to talk more about that. All right, so now on to our conversation. I'd like to introduce two of our panelists this evening. You probably know them, but for those of you who don't, I just want to have them introduce themselves. First, I'd like to introduce Dr. Stephen Lieber. Steve, good evening.
Good evening. Hi, so I'm Steve Lieber. I'm a pediatric neurologist. I've been at Michigan since 1990, and I worked with Rebecca as a student, and good to see you back.
Thanks, Steve. Adam, would you like to introduce yourself?
For sure. I was a student here. I'm undergrad student, med student, and then an OB resident, and I stayed on for faculty. And had the honor of working with Dr. Rao on this project, and it's exciting to be able to do this in a more public forum.
Thanks, Adam. I'm Kristen Collier. I did all my training here, undergrad, med school, residency, and have stayed on, and also had the pleasure of working with Becca as a student here. And Becca, do you want to take it away, introduce yourself and the goals of the project this evening?
Sure. Thanks very much for being here. So I'm Rebecca. I am originally from Texas and then wound up in Michigan for med school, and now I'm in Philly for residency. I'm currently on the HEMONC service in my intern year, so this is kind of an apt time to be having this conversation about suffering and grief. And then I'll be heading into kind of the neuro chunk of my residency in June. But I thought I would start with sort of framing how this project kind of came to be out of my own experiences as a med student, and then sort of jump into the conversation. But so when I was a clerkship student, I sort of had my first experience seeing death in the hospital. And as a med student, I often felt most of the time like I was sort of flitting between experiences, like momentous experiences in other people's lives, whether that was a first-time diagnosis or prenatal counseling or the death of a loved one or the birth of a first child. And for me, I felt often like I would just like open my eyes from I was reading or preparing for my next presentation. All of a sudden I would be in this like huge encounter that I just was like, how am I here? I'm just like in this room with this crazy thing happening. And so the first death that I saw felt very much like that. I was in my M2 year, and I was in the team room where there are other resident teams working who are not on teaching teams, but they're kind of like working as hospitalists. And one of the residents who I kind of didn't really know walked up to me and the sub-I that was on the rotation with me and said, have you seen anyone die? And I was like, no, I have not. And the other sub-I said the same thing. And he said, do you want to? And first of all, it was a very kind of odd encounter. But I said, like, okay. So we went up to this patient's bedside, and it was a man dying of cancer, and he was pretty young, and he was just alone in his room and didn't have any family there. And the TV was on in the background, and we just stood at the bedside for 30 to 60 seconds, just like watching him, basically. And then we left the room and went about our various other tasks that we were doing. And then a couple of hours later, the resident said, that patient passed. Do you want to come to the bedside and see a death exam? So we went back upstairs with him, and as we walked up to the room, there was a nurse in the room just like weeping over his body. And the resident kind of pronounced the patient dead. Again, like just the only thing playing in the room was the TV. And we walked out, and then the resident was like, here's what the death paperwork looks like, and started filling out the paperwork, and then was like, okay, well, that can be kind of heavy. So if you need to take a walk, take a lap if you need to. And I really remember thinking, like, I was just like in shock, kind of. I didn't really take any medical knowledge whatsoever from the experience. I just remember standing at the bedside for that minute or so, just like truly in disbelief. Like, I just can't believe I'm sitting here like watching someone in the last minutes of their life. And like I walked around the hospital for a second and then went back to the team room and was like, okay, I guess we'll just keep going on about our day. And that seemed to kind of be the experience, like frequently, like all of a sudden I'd be in the operating room watching a baby like be born for the first time. And then, all of a sudden the dad's like putting the baby in my arms, and the attending's looking at him take pictures of me with his baby. And I'm like, I swear I didn't ask for this. I don't know what's going on right now. And I'm just kind of turn around and have these different things happening. So until there was a case, when I was a sub-I and I was doing a gen peds sub-I, and had a case where there was a toddler who was developing completely normally and meeting all of his milestones. And then at about 16 or 18 months, started losing his milestones like one at a time. And by the time I met him, this was his third or fourth hospitalization. And he like could no longer talk, and he could no longer walk, and he could no longer crawl, and he couldn't turn himself over in bed. So he was effectively attached to his mom like at all times. So it's actually his mother who was sleeping in the hospital bed with him sleeping on top of her. And that experience was the first like experience that I had as a med student that no longer felt like I was just sort of flitting in and out of people's lives. It felt like it like gripped me. And the other ones felt very kind of ethereal. And this one experience, I really like grieved over the family's experience and suffering. So that's all to say, that's kind of how I got interested in like, how do other physicians go through this profession and have these different encounters where sometimes it hits you kind of, sometimes it doesn't, but you're in close proximity to this extreme level of suffering so much of the time. And I wondered, how do other doctors relate to the suffering, and do they make meaning of it, and how? And that's kind of where this project came from. So the first question, I guess, that I, with that in mind would open with is just kind of, can each of you talk about a case that you remember like really gripping you? One of the first cases that you like struggled with and grieved over?
It's a very a respectful group of panelists. I'll jump in. Um, I think a big part of my experience of being a resident was feeling enchanted or kind of a sense of disbelief about the technologies that we had available and almost like the omnipotence of those technologies. Like if I got better with suture, if I got better tying knots, if I got better with the instruments, if I got better making calls, if I got better reading the fetal heart rate tracings, um, things would be good for other people, and that increased competence would lead to perfect outcomes or better outcomes. And then when I was on the chief resident on labor and delivery, we had a mom. I don't know how to tell the story other than the mom ended up dying on labor and delivery. She gave birth, um, and um, she had an amniotic fluid embolism. And, you know, for those of you who have spent time on labor and delivery during a moment like this, first it's like the team that I was with, and then you call another person in, and then you end up calling the people from the SICU in, and all the most impressive people that are at the institution who deal with kind of care at that level showed up. It was a dream team of kind of the best people that I could have imagined being in the room. And it's like, okay, I'm a chief resident. I wasn't able to fix it. But then person after person after person who showed up couldn't fix it. And after she died, it just like it cracked my, it was like a moment of like I don't think I understood that we weren't able to fix everything, if that makes sense. Not like on a cognitive level, like I guess I would have understood, like if you told me that sometimes people make mistakes, but this was a situation where like the weight of the institution, the blood bank, the ICU, the anesthesia, the everything was there, and we still failed. And I think that on a deep level, it cracked my sense of like that we can X, Y, or Z. It kind of contextualized kind of what we're doing, that we're fighting upstream, and that our technology is so amazing that it gives us the illusion of control, and that is an illusion on some level.
Becca, you raised interesting things, because I don't know if I have an answer to why I react the way I do sometimes, and other times react differently. So sometimes I'm taking care of a patient who is very sick, a kid who has in a car accident in the ICU, and the child dies, and I feel sad, but easy to go on to the next case. And other times I have to really go for a walk afterwards before I even do something with the next patient. I think most commonly there's I feel bad, but let me go on to the next patient. Let me perhaps sit and talk to other people and briefly debrief, but it's going to hit me down the road. I commonly tell the story that I'm having supper, and suddenly my wife looks at me and says, "What's going on in your head?" And I said, "Something that happened didn't work at work today with a patient, or yesterday," and it just like all of a sudden came out. But it's also interesting what Adam you raised. Um, it's not always the death that does it, but our our sense of competence or incompetence, and and uncertainty. So it's not always dying. The things that hit me the hardest are the kids, like you talked about, Becca, going downhill, um, or with really challenging diagnoses, and you can't figure that out. Um, and you do your best, and you just feel like I have to think of something. There ought to be something I could do, and you become very attached to the patient, to the family members, um, and they're expecting you to come up with an answer. You're expecting yourself, and you start to feel very, very incompetent. And if it actually goes to the point that they're losing all their skills or they're dying, you feel like, you failed. There should have been something you could have done a little bit better. And again, rationally, you can blow it off. I can't know everything. Nobody knows everything. Sometimes if I can just put happy endings in a story. When I first came here, there was a kid in 1993 who was a 9-year-old boy, just terrible. He was having all kinds of seizures and abnormal movements and losing his mentation fairly subacutely, in the hospital for months, and then kind of stabilized. We never figured out what he had. In 2007, the diagnosis came out that fit him perfectly. Um, I went looking for him. I couldn't find him. And then I saw a name on a door in the hospital 5 years ago, and it turned out it was his son, the same unusual last name. So I called and I said, I'm not sure that this is my business, but this is Dr. Lieber at Mott. Were you really sick 26 years ago? And he said, yeah, I was in the hospital for months. I don't remember a whole year of my life. So I met with him, went through the whole diagnosis. He was listening very calmly, and then got up, put his head on the wall, and just started crying. And it was just like one of the most touching things. And it was this reverse from, I had no idea what was going on, to looking at a good outcome. So it was the extremes of frustration and joy. Um, and, uh, and I think that's kind of encapsulates what we're doing here.
Yeah, it's interesting. I have one story that really, I think, sticks out in my mind as something I just want to share. And it has very similar themes, Adam, to what you talked about, where I think the vocation of medicine cracked for me in a way. So I was a third-year resident here in internal medicine, and my chief resident, Jake, got sick. And I have permission to talk about him from his family. So Jake was one of our beloved chief residents who everybody loved. He was the type of doctor everybody wanted to be. He was kind, he was funny, he was smart. He saw the humanity in each person that he took care of. He loved his co-residents. He loved his patients. So he was our chief resident. He was interviewing for fellowship positions in academic cardiology, flying all over the country, one of our chief residents, and he started losing weight. And he looked tired. And we said, you look tired. And he said, I'm tired, right? And so he returned one evening in the fall from a trip to University of North Carolina, came home from the trip, and he said he couldn't breathe. And so his friends took him to the emergency department here, and they found that he had massive hepatomegaly. His liver was huge, pushing up against his diaphragm. And he had massive, like cannonball lesions, like masses in his liver. He was admitted to our hospital. And we thought, we hoped he had something easy. And he was diagnosed with a terrible, terrible disease, of which I won't even say its name because I'm still angry at the disease that took my friend. And similar to Adam's story, the department chairman of medicine at the time was an oncologist. We had a specialist at our hospital at the time in his very rare disease. Yet Jake died. He died on our watch. And just like Adam, I think the vocation to me at that time cracked. Like I knew that, that death was possible, but I just thought, again, if we had one more scientific breakthrough, if we had one more piece of information, if we just worked harder, that medicine could be our savior. And I learned at that point that I had made medicine into what theologians call an idol. I had placed unrealistic expectations onto the vocation of medicine that it couldn't handle and that it didn't deserve. And when your idols come crashing down, it's very painful, but the right order of things shines out of that. But Jake's death taught me a lot of things. And one of them was the right position that I should have in my mind of medicine, and that there are limits to medicine. And that path also set me on the current path I'm on, seeking out the faith that I now have as a Christian person.
you all kind of, I think, bring up the idea of like, of our powerlessness in these situations. And I'm, I guess I'm curious as well over the course of this. Like, I think we deal with patients a lot who will talk about like doctors that have changed their lives and the trajectory of their lives. But I'm curious if you feel also that, we are also affected by our patient stories. And I'm wondering like if you remember a case or a series of cases or just like experiences that you feel like kind of like changed how you relate to the world. And maybe it's the same ones that you kind of have already described that sort of changed the way that you think about medicine. But I'm curious too about whether any of these encounters sort of like changed your personhood, like yourself and how you felt about yourself.
I mean, I think one thing that comes to mind is, this idea of what it means to be a medical professional. I think the professionalism that I was taught when I was in medical here at the turn of the century was one where, medical professionals are professional. They have this sort of, as many sort of this thing that's written about of, you have this detached concern, right? You have concern, but it's detached. And that's the way, right, that you need to be, which was taught to me. This is how you protect yourself. This is how you don't get too engrossed in the suffering that you see. And this is the way that you make it. And I have to say, I embody that, I think, pretty well. Like, most medical people do what they're told and they do it really well. And I felt a thick callus on me that was protective, but I think honestly started like spiritually, emotionally, physically removing me from the patient into whom I went into medicine for. And a series of experiences probably ripped that callus off. Probably myself, getting older, having children, watching my parents get older, being the primary care physician of patients who have died under my watch. And it's I'm actually very thankful for the fact that that callus has been ripped off. And I think about, as a Christian woman physician, I think now my role model is, Jesus Christ is the great physician. And I think about how in the gospel accounts, the great physician weeps. Jesus wept. And if Jesus can cry, I can cry too, and I think about the lament that I have for my patients. And I think if you stop having lament for our brothers and sisters who die, I think that you need to like check yourself and maybe think about, do you really belong in this vocation in which we are engaged with people at the limits of their life who deserve our full attention and our full presence in the midst of their suffering. How to do that obviously takes discernment and how you flow in and out of these moments, as Dr. Lieber talked about, depends on various circumstances. But actually, I now think actually leaning into these feelings and leaning into the discomfort and leaning into the suffering in a way actually is how I feel most alive in the vocation, contra the detached concern I think that I was taught to have in my professionalism development courses here as a medical student in the early 2000s.
I mean, I can feel the same ways in terms of when there's a sincere and not just a platitude when I'm talking to somebody about their sorrows, their grief, and I'm feeling it too, particularly when I get to know people fairly well. But in the opposite direction, the interactions with people can be very uplifting and confidence building. So it's very easy all day long, like Adam and I were talking about, feeling you can feel incompetent and I should know more and I should do more and work harder. If I would stay a little bit later, maybe this patient would be happier. But there's so many times where I feel like I haven't solved the problem and I've told the patient or family that, and they've turned around and said, "Oh, but you've made our life better." And it takes away the feeling of incompetence, and I can go home breathing a little bit better and saying, okay, I'm not the 21st century doctor who has solved every medical issue with all the sophisticated tests and treatment, but I can in many ways be satisfied being the 19th century doctor holding somebody's hand and making their life better. And that's okay. And that's actually, if the families feel like I've done a good job with that, I can go home, and breathe a sigh of relief. So.
I have a lot of moments that I'm reflecting on, but I think oddly enough, my kind of leap as an empathetic doctor didn't happen.
Adam froze. Anyone else frozen? Okay. We'll wait for him to come back on. There we go, Adam.
Sorry about that. There's something odd about people becoming doctors when they're like 26, just because most 26-year-olds are generally healthy. And it's hard to have a sense of what kind of vulnerability a person's experiencing when they're coming to us for care. My wife and I had a really complicated pregnancy loss and then subsequent diagnoses, and it was like easily the worst time in my life. It was a really hard time in my life. And the experience that we had is like we went to the neurologist and I had delivered his baby, and then we went to the hematologist and I had taken care of a family. And so like we went from place to place and I felt like such an insider. And people kept on using the terminology like, oh, because you're a VIP, will blah, 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 blah. And I really had that experience of feeling like a VIP, of like showing up and getting people's phone numbers and making sure that like we were hooked into the system and getting awesome care. And then we didn't know if we were going to try to get pregnant again. And we ultimately did try to get pregnant. That was really, really terrifying. And we had people holding our hands through the whole process. When my oldest son was born, there were like 20 people in the room, which is not like a normal thing on labor and delivery. And like the head of MFM was sitting there crying. Like tons of people were just like there crying just to be with us. And I just have I had such a lived experience of that vulnerability of being a patient, that when I'm taking care of people, some people come in for a UTI. I'm like, oh, you need macrobid, go about your life. Like, you don't need me to like hold your hand through this. But there's certainly many moments where people are so at the most vulnerable that they could imagine being. And I think similar to what Steve's describing of like reaching out your hand, like the ideal is to marry the 19th and the 20th century, where you're getting like awesome care and kind of like, just so you know you're a VIP, I actually care about things going well for you. It's not just that I'm like the guy who can push the buttons and make sure that the right thing comes your way. I'm thinking about one specific patient who, when I was chief resident, I got called in because they thought that it was a pregnancy loss. And then I put the ultrasound probe down and um, there was no fetal heartbeat. And so I told her that she had a pregnancy loss. And I just remember so clearly like this like wail, that like the sound of her wail. I can hear it in my ears right now. Later on, she and I have become very close. And later on, she told me that she actually like hated me for a long time because I was like the person who delivered that news. And then I ended up taking care of her for a very long time and ultimately took care of her through a subsequent pregnancy and delivered her baby. And it was like one of the best moments of my life, of just kind of like going through that, of the pain and the goodness, similar to Steve's story, with the first patient that he was describing, of kind of like being with people on the ups and downs. That's something that usually you experience in your personal life with loved ones, like you're there for the ups and downs. But this is like kind of strangers. Like I don't have all these people's phone numbers. I don't know where they live. I've never been to their house, but I've I told Kristen that I just read the book The Goldfinch and I really loved it, for anyone who's looking for a book recommendation. But at the end, Donna Tartt, the author, writes about like the stars are beautiful because there's darkness in between. And I was kind of reflecting on Steve's comment about kind of like being in the presence of darkness. I think that we are really in the presence of darkness, and it allows us to appreciate the stars, right? If it was all stars, you wouldn't know that there were stars. It would just be like brightness. But I think the proximity to suffering kind of gives us a sense of like, oh, things went well this time, and or like the interventions worked this time, and to have a sense of gratitude for that.
I also think that this stories inside of us come out in other contexts. So if rather than looking at how religion and spirituality affect our life in the hospital and our reaction to things, I think if I am thinking about religion, involved in prayer, things come out. It's the stories from the hospital that pop into that. You know, every person has ultimate worth. I think about the 15-year-old with cerebral palsy drooling in a wheelchair who gives me the biggest smile in the world when I come into the clinic. Um, and it illuminates my religious beliefs when I bring the hospital into that kind of context, and not just the religion or spirituality helping me in the hospital.
And I think about what Adam said about, that the stars are only beautiful because there's dark in between. Although medicine has been an incredibly painful path to be in some ways, I just think of the gifts that it has provided me. And I think really is a gift to be able to, productively wonder about our own mortality and death and dying. It's the reality that life has its limits to me now that actually gives life its meaning. And that is actually the bed through which relationships have the capacity to grow that otherwise I wouldn't be able to have, honestly. And so I think, Rita Sharon, who's the mother of narrative medicine, Adam and I have both done some narrative medicine training, says that, being in the presence of suffering sort of gives you the knowledge of like the cost of this life. And you get to discern like this life, its worth is what she says. And so I think physicians have a unique ability because of our proximity to suffering to have this productive wondering about limits and death and dying in our own mortality, which if done in the right way can provide fruits that actually other people might not have. And so to not waste those opportunities and to reflect upon them, to be able to bring this productive wondering to my own reality as a person who has limits and who will die, but also to my future patients. I think those gifts, although born out of sort of the valley, I think have been something that I've more appreciated as I've gotten older and have become myself more vulnerable in this space.
This is actually something that came out of the result of all the different interviews that I did at the end of this project, was also the conversation about like that I started the project talking about grief and suffering and cases that really like disturbed and caused you sadness and things like that. And what wound up coming out of many of the interviews was a discussion about like how much gratitude has been born of these experiences, which I think all of you have talked about in this conversation as well, about like the joy and the suffering are like intimately linked. And actually like I'm in a very different kind of headspace now as an intern than I was as a fourth year med student, which I think is a very interesting time to be having this conversation, because as a intern, I now feel that I am like moving from task to task and you know, as I think when I started this project as a med student, felt like there was a lot of porousness to my being, as far as like when I had this experience of like suffering the first time, that it really kind of like could infiltrate me, kind of. And it was a very like important and meaningful experience for me. And now I feel sometimes in the hospital that it's very odd that I'll go from like one death to another death in the ICU of very tragic like cases, and sort of have about 10 seconds between the two to be like, maybe I'll have one tear come out, maybe, and then literally we'll go into the next room to have a new goals of care conversation, and then the patient will, you know, be also pass away. So, and you know, one afternoon in the ICU, I remember literally going from like one room to the next, back to back, and doing palliative extubations in 2 different rooms, and like walked out of the hospital and just kind of like went home and went to bed. And one of the questions that's come up for me, you know, recently is like, how, like at the time as a med student, when we had these interviews, I was very curious, like, how do you deal with the suffering, and how do you cope with it and protect yourself? And like, now I'm also interested to hear from you about how you now sort of like maintain your ability to be moved by these things. Because I think on the flip side, it can be probably very easy for things to become pretty routine. So I'm curious, like, do you still feel moved in your work, and how do you maintain that ability?
You and I spoke last week and we were talking about this. And I've spent like most of the last week thinking about this. I think it's like maybe the question, right? I have 2 metaphors that I've come to. The first is that it's kind of like love, right? It's like, as a med student, you're like going on a first date, and there's something interesting and it's engaging. And I think the question that you're in now as an intern is like, you've been dating for 6 months or 2 years or whatever. And it's like, how do you keep the romance, the excitement alive, right? That's kind of the question with romantic love. But I think it's also the question with like loving your profession, of like, how do you keep the interest, the excitement alive? I don't have a perfect, if you ask my wife, probably some days I do better than other days. Reality and religion is some of my religious background as a Jew, is that Judaism's very interested in the question of, first of all, it starts with the principle that the whole world is created by God, and so the whole world is God's creation, right? So everything's like worthwhile on some level. But having said that, there's still a separation between like the holy and the mundane, right? Like 6 days a week, it's not the Sabbath, and then on the 7th day, it's the Sabbath, right? So even within like an entire time and space that's worthwhile, there's still separation between the sacred and the profane, the holy and the mundane, like a sense of like just your normal weekday, and then Shabbat, right? Like kosher food, not kosher food, separating a separation as a way to like appreciate or have a sense of awe, or prolong a sense of awe. Yeah, I don't have a perfect application for like the clinical space, but I certainly emotionally I feel that in the clinical space, right? Like most of the time I'm in the mundane. Like most of the time I'm prescribing macrobid for someone's UTI, and doing a pap smear for somebody, and doing like just a bunch of mundane stuff that's kind of like on their checkbox, on my checkbox. And like I think there's a sense of mutual understanding that we're both checking boxes. And then every once in a while, I feel like I tip out of the mundane into a sacred moment. I don't know how to describe it exactly, but these moments where somebody lost a pregnancy, and now they're, I have it on a regular basis where I'm like going through my workday, and someone had a previous miscarriage, and then I do their first ultrasound, and they see their baby's heart rate, and then they're crying. and I'm like not emotionally ready to emotionally engage, but I see them crying and I'm like, oh my God, this is a big moment for them. And it like elicits excitement for me. I think like post-op visits are kind of like that, where someone comes back in, we've done a hysterectomy, and they're like, thank you so much. This was the first month that I didn't spend like half the month bleeding like crazy. And it's just like, it's meaningful. It's hard to describe other than like, there's meaning there. Both of those examples are not within me. It's kind of like, I think a lot about myself as a servant, like I'm there to serve someone else. Like when the person that you're taking care of, the person that you're serving is having a moment, you kind of get like a contact high. Is I think a lot of the experience that where I feel a moment of like holiness. I don't know how to describe it exactly. That's like a metaphor, but just gives you the sense of like not just another prescription of macrobid.
I sometimes have the same stimulation by cases. Different kinds of things. We could go day-to-day routine, and sometimes you'll just be inspired by a patient, or me with kids when kids are really sick, by the parents. Like, how do they go through this and still be such fine, loving people who aren't angry at the whole world and are doing everything they can for their child? And it'll get me out of the mundane and just have all kinds of respect. Sometimes it's the complete opposite. We all have patients where we don't like the patient or we don't like the family, and you don't want to go in the room. You're going to get yelled at. And you say, okay, I have a job to do. I'm a doctor. I'm going to ignore all of that. I'm going to focus on the important thing. I'm not going to let this turmoil I'm feeling in me change my responsibility. And sometimes that changes it. Look what I'm doing here. Getting past the barriers and doing what I should be doing and doing the right thing. And sometimes that gets you out of the mundane, everyday kinds of things, even when you've had to, because you've had to struggle to get there. I think it's because of the struggle.
Yeah, Becca, your question is a really prescient one, right? About how do you cope? I mean, I think for those of us in clinical medicine, like we are always surrounded, as Adam said, by like the darkness and the reality of death. And how do you make sense of it? I mean, that's the like lifelong question of theologians and philosophers since the beginning of time. And especially for people of faith, I think that was when my chief resident died, I think that was the beginning of my struggle with faith and thinking if God exists and he's all good and all powerful, why did my chief resident die? Like how do these moms die? Like how is this allowed to happen? And if God exists and he's all good and this is what happens, like no thanks, like I don't want any part of this, right? And that anger that I had was really an existential wrestling that I think actually probably most of us go through when we see the horrors of the hospital and the horrors of life, and there's no like perfect way to deal with it. I mean, I'm very thankful for the Christian faith that I have now that I didn't have when I was a medical student or resident here. But, it is my current, I think, privilege to sort of have faith in the promises of God. And as someone who does primary care and takes care of mostly older people who many of them have died or are on their way to death, as we all are at some stage, the only thing that gives me some degree of peace now that I didn't have back then is, hope in the resurrection of glorified bodies, hope in every tear being wiped away, hope of all things being made new. If I didn't have that, I'm not sure like where I would be. And again, not that I'm not fully also grieved by the loss, and not that I fully understand, why suffering exists. But even the ability to pray for my patients with the boys in the evening and no, thank God it's not all under my control. I think Adam was speaking to this earlier. Like I used to think when I was a medical student, if I did things right, people got better. If I didn't do things right, people didn't get better. Now, actually, I might not do things right and people get better anyway, or I might do things perfectly fine and people get worse. And like, how do you make sense of and how do you come to some degree of comfort with the uncertainty that you will see? I think the last thing I think you asked too about like you know, do we still feel, I think I feel things more now than I did when I was some like hotshot 26-year-old doctor. Like I was like, what's the problem? You know, now I'm like a mom and like older, my parents are getting older, like, you know, and like understanding my own vulnerability has helped me enter into the encounter with the other as gift, honestly. And I think lastly, I think my patients have taught me so much about what it means to have grace. I mean, I have it, you know, so many patients, I've had to tell terrible news, like you're like part of the before and after in people's eyes. Like you tell them something, now it's like the after, right? Some terrible diagnosis. And telling patients, you know, things over the years, the witness that they've been to me about what it means to handle things with grace, and the things, the way that they've lived out their lives as a testimony to faith, to me has been incredibly, incredibly powerful. So yeah, no, I encounter it all as gift at this point. Yeah.
The other thing that I'm just thinking about right now is that there's like developmental milestones in growing up as a doctor. And I think that the developmental milestone that you're in as an intern is essentially the experience of skill acquisition, like rapid skill acquisition, where you like live in the hospital and you spend all your time in the hospital, and then you get like a free night, and then Adam Baruch contacts you and asks you if you want to Zoom. And it's amazing because you're investing in a skill set that in like 10 years from now, you're going to be a really, really, really competent doctor. But right now you're in that acquisition of skills phase. And I think that it's profoundly dehumanizing. Like you don't always do things that you want to do, and you don't always dress the way you want to dress. And you don't, you don't talk about things that you want to talk about. And I think on a deep level, it's hard to see the humanity in others when you don't feel like a human yourself. And so I think that there's a lot of delayed gratification from the time that you do like pre-med classes to studying for the MCAT, to getting into med school, to like doing the M1 coursework, to the like each step of the way is like in the future there's something better. But I think that specifically intern year is a particularly hard time for individuals, and then it's hard to see another individual as meaningful when you don't feel like you're being treated as if your experience is meaningful. Yeah, I'm only a few years out of residency, but I definitely have like a much different sense now about like I went on a very long bike ride today. I didn't do that often on Thursday afternoons as an intern.
This is like kind of the basis of another project that I'm sort of interested in, is like actually following people as they go through the different steps of training and doing the interviews, like first year of med school, second year of med school, intern year, senior resident, you know, on, and just like revisiting the same topic about like how, like in real time, how people kind of morph. And as a med student, I think I felt like my world was like so small and confined, like to me, of just like, I have to get this specific amount of studying done, and I have to take this test next, and I have to do this X, Y, and Z and whatever. And like, I simultaneously felt pretty much totally like irrelevant in the hospital and clinical spaces, because like I was like, don't have any skill set to offer. You're just like learning, and that's like fine, and that's just the way it is. And like now as an intern, I feel this like kind of like as a kind of a cog in the machine, where like it could be me or somebody else typing the notes every day and like putting the orders in, and like my brain is not doing something particularly special that anyone else's brain can't also do, who like is just able to like sort of gather the information and figure out like what the next task is. And I find it to be like I found it to be like very humbling to realize like, and you all have spoken to this, that like part of becoming a doctor is acquiring like a great deal of competence and a skill set, but also part of the process for me this year has also been um like none of this is about me at all actually, and that I think will probably like, I'm curious if it kind of continues to be true and feel that way in like a positive way, honestly. Like I feel that like my realization this year has been like I am like the least relevant to this process. Like we exist in a healthcare system that there's forces at play that I will like never be able to change. And then that like that's just the way it is, but I'm still gonna like come to work and do the best job that I can every day, even if it's actually like exactly the same as somebody else is able to do. But that's all to say, I guess I'm kind of like curious, like what other developmental milestones you feel you go through as a physician. It's like very interesting to me that the idea that kind of your relationship of like how you feel useful changes.
I was going to say, I don't think people should overemphasize these developmental milestones because I can see working in a team, it's not always hierarchical, and the medical student or the intern sometimes has more insight as to what's going on and can voice the non-medical aspects of things um, better than anybody else. Can be sometimes stepping back and looking at what people are saying, what they're really meaning, and can bring it up as a team. And I learn a lot from people quote lower down on the hierarchy. I'm always learning and saying things. So I don't know if it's always that strictly you're a low cog in the machine. Um, the it's really a team, and people talk to each other and hopefully listen to each other.
Other thing that I always think about it, I think I agree with you that we're all cogs on some level. That we work in these big systems, and I actually think that there's something beautiful about that. Like I want to be a really good cog, right? Like the work is really important. Because we transfuse so much blood. I was like, I should probably replenish the blood stock supply since I keep on ordering to give it to other people. And so I go there and I laying there and like with the IV in my arm and donating blood, and I look around at all the people who are like participate, that like the cogs aren't just in the building, and like even the blood goes into a plastic bag that's made in whatever country it's made in, and then it's shipped across the ocean. Like the machine is huge, and for one patient to get amazing care, it actually requires like no global pandemic and shipping to happen and all these kinds of crazy things. And I think that I take my responsibility as a cog really seriously. Like I want to be the best cog I can be today.
I feel very inspired by that. I'm gonna every day for the next few months wake up and say like I'm gonna be the best cog I can be today. um I think those are like kind of the big questions. I don't have any other major questions, and I really appreciate you all like sharing your time and your thoughts and your stories. And one of the things I think I discovered over the course of this project that you and I talked about, Dr. Baruch, is that like the process of storytelling in and of itself is part of the process of kind of like making meaning of these experiences, which I certainly think is true and is part of the reason I love having these conversations so much, as well as like the conversation that you and I had last week, kind of in preparation for this, was maybe one of the first times I've really sat down and gotten to think about these things again since you know, since I had a little bit more time 4th year. So it's fun to revisit, and I appreciate you all being here.
Thanks, Becca. I would just really appreciate your courage to be able to, you know, with the bandwidth, I know it was very limited as a medical student, as an intern, to dive into this space. And yeah, I encourage you as so many of us are lovers of narrative medicine to think about, right, sort of the stories, right, that you tell yourself about how you make sense of the world around you as a doctor in progress. And we're all happy to help continue that conversation, because it's best had with a conversation partner, like any good story. So we appreciate you. And again, thanks everyone for coming out. Thanks, Dr. Lieber, Adam, thanks for being here. And to all the students who came out tonight and friends of the program, really appreciate you. If anyone wants to continue the conversation, reach out to any of us. Adam and I have office hours over the next several weeks. Happy to have conversations in office hours too about the themes we brought up tonight. And to everybody else, good to see you all. Thanks for coming out, friends. Till next time.
Thank you guys for being so vulnerable and telling all of these stories. They were